Today we will do an introduction to lung ultrasound. So what are the indications of lung ultrasound? Point of care ultrasound, otherwise known as POCUS, exam is nice because it can be performed at the patient's bedside and can be used in acute clinical situations to aid in making a diagnosis or providing a qualitative assessment of a patient. It's also nice to use as a quick preoperative exam. It can also be used to diagnose pathology. For anesthesia providers, it can be used to check for pneumothorax after nerve blocks and line placement. And it can also be used to check for diaphragm movement. So advantages of lung ultrasound are that it provides fast and immediate results. It's a non-invasive exam, meaning it causes minimal discomfort to the patient. It can be used for dynamic assessments and serial monitoring. Disadvantages are that it's highly user-dependent, meaning that if the operator is a novice, they may not get the best images or the most accurate exams, and it does not provide any quantitative analysis. Probe selection. For lung ultrasound, you can use a linear probe. It's great for superficial structures, such as looking at the pleura and evaluating for lung sliding. You can also use the curvilinear probe. It can look at lung sliding like the linear probe, and can also evaluate for effusions, consolidated lung, and it could also be used to evaluate the diaphragm. You can use a phased array probe as well, if that's what you have available. Lung ultrasound technique. You can scan for the lung in multiple locations on the chest wall. To evaluate for pathology in the upper lobe, you will look at the upper anterior point. For the middle or lingular lobe, you would put your probe at the lower anterior point. And for the lower lobe, you would place the probe at the mid or posterior axillary line, as shown in the diagram on the right. Let's look at some basic lung anatomy. Remember, the chest wall is made up of the rib cage, sternum, thoracic vertebrae, connective tissue, and intercostal muscles. Let's zoom in and look at the pleura. There are two layers of pleura, the visceral pleura and the parietal pleura. They cover the lungs and line the inside of the chest cavity. The two layers of pleura move over each other as you breathe. The diaphragm is posterior to the lungs and it controls inspiration. Let's look at the main components of a lung ultrasound image. Ultrasound waves are completely reflected by air. So in air-filled lung parenchyma on ultrasound, the image appears dark, as seen here on the picture in the left. In lung ultrasound, we use and look at surrounding structures that are detected by ultrasound waves, such as the rib, which is, since it's bone, will show up as bright, the pleura, structures like the liver and diaphragm. We also evaluate lung ultrasound looking at artifacts that are generated by ultrasound. So in the ultrasound picture on the right, you can see rib, which shows up as bright. You can see pleura, which looks like a shimmering line. And then you can also see skin, subcutaneous tissue, and muscles on ultrasound. Lung, on the other hand, appears dark. Let's look at what normal lung sliding looks like first. In the diagram on the left, that's an example of how the probe should look. You place the probe in long axis over the apex of the lung. The probe indicator should be pointed towards the head. The image on the right demonstrates normal lung sliding in the pleura, which looks like a shimmering line. When I play this video, you can see that the movement of pleura is shimmering and bright and has also been described as ants walking in a line. Now let's look at pneumothorax on ultrasound. As you can see, in the presence of a pneumothorax, air will be present between the parietal and visceral pleura. As air completely reflects ultrasound waves, the visceral pleura will not be seen, and so therefore you will not see that nice shimmering line as you saw on the previous slide. There's no lung sliding. And here's a video of what a pneumothorax would look like under ultrasound. Lung sliding can also be evaluated in M mode, which stands for motion mode, reflecting motion of a tissue. It is essentially a one-dimensional single beam that can be used to produce a picture with motion signals. In a normal lung with lung sliding, this is what M mode would look like, as shown on the left. It's commonly called the seashore sign. Because there's lung sliding or movement of the visceral and parietal pleura, you can see two interfaces. It's commonly called the sea and the sand. When there's a pneumothorax or an absence of sliding, we get what you call the stratosphere sign. There's no sand because there's no lung sliding. We'll talk about interstitial syndrome next. Interstitial syndrome comprises of a variety of things such as pulmonary edema from fluid overload or ARDS, interstitial pneumonia, or lung fibrosis. B-lines will show up in patients with interstitial syndrome. They appear as comet tails, which are artifacts from alveolar air and septal thickening. B-lines are transient hyperechoic lines. Diffuse B-lines indicate pulmonary edema. You can have focal B-lines as well, and that can represent consolidation such as pneumonia. The B-line artifact is created by repetitive reflections of the ultrasound wave within the lung parenchyma because of a higher concentration of physiologic or pathologic fluid. In an ultrasound window or view, greater than 3 B-lines indicate or is maybe a sign of pathology. And here's a video of what multiple B-lines looks like on ultrasound. Keep in mind that healthy lungs can also have B-lines, but typically only 1 to 2 in each ultrasound window. Here is an example of B-lines in a patient with ARDS, shown in the 2 images in the top panel. You can see multiple B-lines, 3 or more in each window. Let's talk about pleural effusions next. Ultrasound can rapidly identify simple or complex pleural effusions. A pleural effusion is a buildup of any excess of fluid, exudate, malignancy, or infection between the visceral and parietal pleura of the lung. Just to review, the visceral pleura is superficial to the lung and directly covers the entire lung. The parietal pleura is the outer layer and attaches to the mediastinum, the chest wall, and the diaphragm. The lung's visceral pleura and parietal pleura are separated by the pleural space. The pleural space is more of a potential space. It normally holds a very small amount of lubricating pleural fluid to aid in the movement between the 2 different surfaces during normal respirations. However, in pathology or volume overload, excess fluid will build up between the 2 layers, as shown here in this diagram. Here's an example of what effusions look like under ultrasound. In the ultrasound image on the left, there is no effusion. And then in the image on the right, the dark fluid or hypoechoic fluid is seen above the liver and diaphragm. In a supine patient, to scan for this ultrasound image, you should place the probe in long axis over the middle or posterior axillary line. You should place it over the interface between the diaphragm and the lung, just above the liver on the right side or above the spleen on the left side. Here is a diagram of probe and patient positioning. For a supine patient, place the probe at the mid or posterior axillary line. Probe should be in long axis configuration. For a patient in the sitting position, place the probe just medial to the medial edge of the scapula. To assess for pleural effusion, you want to place your probe where the diaphragm meets the liver on the right side or where the diaphragm meets the spleen on the left side. Angle the probe up towards the thoracic cavity. Fluid will appear dark or anechoic. If fluid is seen, you can slide the probe further up the chest to evaluate the size and extent of the infusion. Here are some more examples of pleural effusion. The image on the left shows an effusion on the right side. You know this because you can see the liver in view. The image on the right has an effusion on the left side. To summarize, lung ultrasound is a quick and simple method to evaluate pathology. You can use the linear, phase array, or curvilinear probes. To rule out pneumothorax, look for lung sliding in at least 2 to 3 windows, meaning 2 to 3 different rib spaces. Diffuse B lines indicate interstitial pathology such as pulmonary edema. Pleural effusions can be evaluated in a supine or sitting position. The probe should be placed in long axis over the mid or posterior axillary line.